Hello, and thank you for joining me today. I'm Chris Wallis, a urologic oncologist at the University of Toronto, and I'm pleased to speak to you today about prostate cancer screening in 2024. Most of you will know that prostate cancer is the most common solid organ cancer in men and the second leading cause of cancer-related deaths. The Canadian Cancer Society estimates that each year, almost 25,000 men will be newly diagnosed with prostate cancer, and more than 4,500 will die of the disease. Clearly, there's opportunities for improvement, and early detection is one approach for nearly all cancer sites that has been shown to have some benefit. Early detection of prostate cancer is premised on PSA-based testing, and this was introduced fairly widespread in Canada in the mid-1990s. As you can see from this figure taken from the CMAJ journal, the introduction of PSA testing was associated with decreased rates of prostate cancer-related mortality. As you can see, by the early 2000s, we were at well below historic levels of prostate cancer-related mortality and a real impressive decline from peaks in the early 1990s. When we compare this to other cancer screening tests, you can see that the overall survival effects are relatively limited for all, but when we compare between disease sites and screening approaches, PSA testing actually performs relatively well. The survival benefits for PSA testing are estimated to be larger than mammography or fecal occult blood testing and relatively comparable to colonoscopy. And so this, I think, should help contextualize the value of PSA screening in our populations when we think about all the other tests we do. So while we know that PSA-based prostate cancer screening can reduce prostate cancer mortality, it's not widely recommended, or certainly there are organizations that don't recommend PSA-based testing. And predominantly this relates to two issues. One is overdiagnosis and the other is overtreatment. And so overdiagnosis comes from the lack of specificity of PSA, leading to a high burden of investigation in the detection of clinically indolent disease. As a result of these concerns, in 2012, the U.S. Preventive Services Task Force recommended against PSA screening with a grade D recommendation stating that there was moderate to high certainty that the harms outweighed the benefits. Shortly thereafter, in 2014, the Canadian Task Force on Preventative Healthcare had a similar recommendation against PSA testing for prostate cancer, citing low to moderate quality evidence. This leaves us an unmet clinical need. We have knowledge that the use of PSA testing can reduce prostate cancer mortality, and yet it comes with harms. And so we're looking for a way to move forward, preserving the mortality benefits while reducing overdiagnosis and overtreatment. And there are two main approaches we need to take here. First, as we address overdiagnosis, we need to reduce the number of men being diagnosed with low-grade clinically indolent disease. And in part, the way we reduce the morbidity associated here is to reduce the number of biopsies performed. Secondly, we need to reduce overtreatment, and that is to reduce or eliminate the treatment of low-grade clinically indolent prostate cancers. So first, if we consider how we can reduce overdiagnosis, I'll draw your attention to the most recent version of the Canadian Urological Association guidelines on prostate cancer screening. And here you'll see in the bottom line that in men who have an elevated PSA, rather than jumping straight to biopsy, the guideline clearly advocates for the use of adjunctive strategies. This is to allow better risk stratification and identification of those men who are at highest risk of harboring prostate cancer, such that we're focusing our biopsies on those men who have the opportunity to benefit. So when we look at the adjunctive tests recommended in the CUA guidelines, there are a number here. Multiparametric MRI leads the list at the top, and this is in part because it can reduce the number of biopsies performed by about 30%, while also actually increasing the diagnosis of the clinically significant disease we're looking for. You'll see that a number of PSA-based metrics are here, including percent-free PSA, as well as biomarkers and prostate cancer risk calculators. While risk calculators can be widely utilized, sometimes patients are missing the information necessary to inform them, and biomarkers are not widely utilized in part because they're expensive and they're not well funded. So when we think about how we can improve prostate cancer screening, addressing issues related to overdiagnosis, we know that use of adjunctive tests, and particularly multiparametric MRI in the current Canadian context, can reduce the number of biopsies performed and the morbidity associated therein. We can reduce the diagnosis of low-risk prostate cancer by approximately a third, and we can improve the diagnosis of clinically significant prostate cancer. And this really helps shift the cost-benefit analysis of prostate cancer screening overall. And so when we consider ways to improve prostate cancer screening and the identification of patients with clinically significant disease, biomarkers or nomograms are a way we can supplement MRI. And these can be done in a variety of ways. And I want to bring your attention to one recently developed made in Canada or made in Alberta approach called Clarity DX Prostate. And as you can see here, the use of Clarity DX improves diagnosis of clinically significant prostate cancer compared to either PSA alone or percent-free PSA. While preserving the same sensitivity, you can see that the specificity increases by nearly threefold. And so when we're thinking about ways that physicians can improve prostate cancer screening, the first key role is to just discuss PSA testing and consider the pros and cons of it with your patients so that they're truly informed. We can look at adjunctive tests, including biomarkers, other PSA isoforms, and nomograms in men with an elevated PSA to better understand their risk of prostate cancer. And for men where it's appropriate, referral to a urologist for further evaluation, testing, and potential management is also critically important. Let's shift our focus now to the second issue related to prostate cancer screening. That relates to the overtreatment of clinically indolent disease. Again, a real made in Canada approach, active surveillance has become the worldwide standard for men with low risk localized prostate cancer. In adopting an active surveillance approach, we can monitor patients and identify when they may develop a more aggressive disease warranting treatment while avoiding the morbidity of treating with either surgery or radiation for men who just have low risk disease. And in doing this, we can really hopefully preserve the opportunity to intervene and cure men with high grade or more aggressive disease while avoiding the toxicity of treatment for those with more low grade disease. When we put this in context, active surveillance changes that harm to benefit ratio by avoiding morbidity of treatment in those who have minimal opportunity for an oncologic benefit from prostate cancer treatment. So when this evidence is put together, we can see an evolution of screening recommendations from the U.S. Preventive Services Task Force. So from 2012's grade D recommendation against PSA-based prostate cancer screening, in 2017, we see a grade C recommendation, which really advocates for an individualized shared decision-making approach. Unfortunately, Canadian primary care and preventive services bodies have not yet updated their literature, but we do have a guidance from the Canadian Urological Association, which really mirrors many other guideline bodies around the world. And the CUA suggests offering PSA screening to men with life expectancy greater than 10 years. Now, clearly, this is not right for all men, and so a discussion needs to be had regarding the potential benefits and harms, and shared decision making with the patient, his family, and his physician is key before moving forward. For men who do elect PSA screening, recommendations from the CUA are to begin screening around 50 for most men and age 45 for those who have a higher risk due to either family history or ethnicity. When we put this all together, we know that prostate cancer, from an oncologic perspective, is one of the most important public health concerns for men in Canada. Prostate cancer screening, beginning with a PSA test, can reduce deaths from prostate cancer. However, when we do it poorly, PSA-based prostate cancer screening has a significant burden of overdetection and morbidity therein. Fortunately, over the last 10 to 20 years, there have been improvements in both the evaluation and diagnosis, as well as the treatment of patients with prostate cancer that reduce burdens associated with overdiagnosis and overtreatment, and I think really shift the cost-benefit trade-off. So as we close today, I'd really encourage you to consider these data and think about men in your practice who may benefit from PSA-based prostate cancer screening and discuss both the pros and cons of it with them in keeping with the CUA and other guideline bodies. And then for those men who are appropriate, consider escalation of care with further testing and referrals as required. I hope today's session has been interesting and informative for you, and I thank you again for joining me.